Welcome to today's meeting of the Health Committee. Members of the public may like to follow along at London Assembly on social media and use the hashtag AssemblyHealth for this meeting. Can I remind participants to silence your devices? The main item on our agenda today are discussions Oh wait, sorry. Okay, this is right. Sorry, it was the wrong. It was the wrong agenda, but it's the right. No, it's the wrong words. It's the right agenda. Sorry. The main topic of discussion is an emergency meeting on the measles outbreak concentrated in North London. However, we have a few short items of business. Can I first ask our clerk, Hannah Barlow, to confirm any apologies for today's meeting?
Thank you, Chairman. Apologies received from Assembly Member Ahmed.
Many thanks. And committee, can I ask for declarations of interest? Can we note the list of offices held by Assembly members?
Noted.
And can I ask members if they have any disclosable pecuniary interests in any specific items listed on today's agenda? Brilliant. That brings us to today's main item. I'd like to put a warm welcome out to our first panel of guests today, joining us to discuss the measles outbreak in London, and this panel will focus more directly on Enfield. So from left to right, could I introduce Dr. Yimi Chow, Regional Director from the UK Health Security Agency, Nalini Ianja, Consultant in Health Protection, again from the UK HSA, and Dudu Shah Arami, Director of Public Health for Enfield, and Dr. Sonali Kinra, Deputy Medical Director for North Central London. So if we kick off today, Nalini, could I come to you straight away and ask for the update on the current situation in Enfield?
Yeah, absolutely. Good morning, everybody. So if you wouldn't mind, I'll tell you just a little bit about measles, so it'll put everything else in the context of it. So you already know it's a viral illness. It can be quite a severe illness for certain groups, particularly pregnant women, immunocompromised under ones. But even for healthy individuals, it can cause quite severe complications, life-threatening complications of the brain or the lungs, for example. So it's a very serious illness, and we have control strategies in the UK for that. So I'll tell you a bit more about that. It's very infectious. So if you compare it to COVID, for example, it can be 4 to 5 times as infectious. And the control strategy in the UK is to have 2 doses of measles-containing vaccine by the age of 5. So that's the best protection for children, and we aim to get to 95%. So having put that context in place, so we in London currently have 127 confirmed cases of measles since the beginning of January this year. In Enfield, there are 71 confirmed cases of measles. That has been that's 12 more than we reported in the week prior. So our feeling at the moment is it's a situation under close monitoring. We feel it's stabilising, but of course we're keeping a very, very close eye on it and on the response that we've put in place.
Thanks. Yep. So I also wanted to just give people a little bit more of a flavour about the Enfield situation. I think it's just very, it'll be useful as well for me to share some very brief information that I think is contextual with regard to Enfield. For those of you who aren't very familiar with Enfield, we are the 9th largest London borough, so we've got a population of nearly 330,000 individuals. We are a relatively highly deprived borough as well, and in fact our deprivation has worsened between 2019 and 2025, and we use the indices of multiple deprivation to measure that, which is a composite sort of scoring system that looks at things like housing, health outcomes, outcomes for children, older people, employment, income and such like. And we can see that many areas in Enfield have become relatively more deprived during that period. Also, what's important contextually is that we have a higher concentration of children and young people living in those areas that are more deprived. We have a relatively higher proportion of young people as well in comparison to other London boroughs. So we've got around 90,000 0 to 19s living in the borough. So I just wanted to provide you with that information as a bit of context, a bit of a flavour for Enfield. So in terms of the update around the outbreak, obviously all of the partners work very closely together, and that is coordinated locally through what we call an instant management team. And so that's a group of us who are working closely together in a coordinated fashion. It includes members from different parts of the NHS, from the local authority, and our comms and engagement colleagues as well. And it oversees all of the work that's happening. The UK HSA, Nalini and colleagues oversee the infection control element, and the local authority is responsible for supporting that, as well as the sort of engagement and communications element of it as well. And so the sort of engagement and communications that we've been doing, we recognise that it's very important to sort of have that backwards and forwards flow of information with residents about this. And we have also for some time been working with residents to improve vaccination uptake. But in terms of the outbreak, as soon as we recognised we were in an outbreak situation, which was sort of around the end of January, I sent a letter out to all Enfield residents with pupils in Enfield schools and early years settings to communicate with them that we were in an outbreak situation and to advise them about signs, symptoms, and that vaccination was the most effective way of preventing measles, and informing them about how to be vaccinated if they were missing those vaccinations. We've also done quite a significant amount of communication through various channels, such as our family hubs, our leisure centres, our voluntary sector organisations, our faith forum, where we have a wide representation of many different faith communities that there are in the borough, pharmacies, dentists, the registry office. Really, we're looking for all of the various sort of points at which families may sort of operate function within the borough, and we're looking to sort of communicate with them through that. We've also been commissioning specific engagement work that is culturally competent to ensure that we're working specifically with groups where we know that there are lower vaccination, and that's included the creation of sort of short films in community languages that are very easy to share on social media and such like. We've communicated with residents who are living in temporary accommodation, and we are also looking to write out to each household in the borough with through our council tax letters that are going out, I think, this week. There's also been engagement across Enfield and Haringey, and we've commissioned particular pieces of work to take forward and have a more in-depth engagement with communities where there's lower vaccine uptake.
Thank you. We'll be going deeper into that work in a bit, but thank you for the overview. Snarly, was there anything you wanted to add on the update of the Enfield situation?
No, I think just as Dudu have been writing out to various families, we within the Integrated Care Board, which is a North Central London Integrated Care Board, have reached out to our GP practices and also communicating out with the families directly to ensure we rapidly identify the unvaccinated or partially vaccinated children, and ensuring that our practices are equipped with their infection prevention and control mechanisms and strategies, ensuring that they have triage mechanisms in place so that they are quickly able to isolate if there's any child who's presenting with symptoms such as these. So we're really taking a coordinated response across all authorities that are there to ensure that we make every kind of contact count and every opportunity is made available for the families to come forward.
Thanks. Asnali, if you lift it from the base, you feel free to move your mic closer to you so you don't crane your neck.
Chair, could I just add something very quickly? We've also done a lot of work at the initial stage of the outbreak with schools and early years settings. So we've used a pack that was prepared by UK HSA colleagues that informs how schools and education settings should respond should there be a case of measles within their school communities. We've done webinars with school staff to ensure that they and the settings are very that they understand how they respond appropriately when there is a case, and that's enabled schools to really act quickly and provide accurate information to their school communities, and so that the school staff are confident in how to respond appropriately.
Thank you. I just want to come back to the numbers quickly. So, Nalini, you gave the update that we've got 71 cases now, but you mentioned that you believe that that was stabilising. Are you confident then that means that we won't continue to see a large trajectory in the next coming weeks in Enfield?
I'm afraid it's really difficult to say. And at every IMT, we start off with the epidemiology and then say it's not really possible to predict where this might be going. We know that until there are unvaccinated children in the population, and I mean completely unvaccinated, which unfortunately there is the potential for the outbreak to grow. So it's incredibly difficult for me to sit here and tell you where the outbreak might go. But we are seeing signs of stabilising, but we're not at all being complacent about it.
Okay. Well, just to delve into that, what is the signs of stabilisation?
Just that the numbers are fairly static in the last couple of weeks, but that's not to say that it won't go up or down in the next few days.
Okay, so given obviously the vaccine coverage, etc., it's not a situation you would describe as contained at this moment.
We're doing everything we can to control it, but I couldn't say that numbers wouldn't go up. Yeah.
So it's not a contained situation at the moment. And on the numbers, what is your feeling of underreporting? How close to the actual figure do you think that 71 is?
I think we feel like it's a fairly accurate reporting. So it's a notifiable disease. Healthcare workers who see a child with suspected measles, it doesn't have to be confirmed at all, suspected measles have to report it into us. As Judy said, schools are also very engaged, and we hear from schools as well if they hear of suspected cases. And then once they're reported into the health protection team, we then organise testing, or testing is done through local hospitals, and that's how the numbers are confirmed for the weekly numbers that you see. So and we're in close contact with general practice and with hospitals to make sure that we're getting accurate reports of suspected cases. So I'm fairly confident.
Chair, can I just come in?
Yeah, of course.
It's like you say, because measles is a notifiable disease, and we are informed of any suspected cases, and measles being a childhood rash disease, there are many different types of rash disease, and it's hard for clinicians to be certain it's measles. But once they think it's measles, and we think it's circulating, especially with the epidemiology around Enfield, then we are likely to take immediate public health action for both for the case and the contact tracing around that case, especially for vulnerable people like pregnant women and children under 1. So the cases that are notified are much higher than the figures that are confirmed and out on the data. They will have to be verified, and we'll get testing. In addition to that, there's a time lag of the data coming through because of that diagnostic ability. So the figures that we see will be a time lag of what's maybe on the ground, but we do have to respond according to urgent, unverified data so that we can be on top of it. However, once you see an outbreak, it's really very difficult already to contain something as infectious as measles. Measles is very infectious. Not only is it very infectious, the rash is, once you get the rash, people are already infectious 4 days before the rash, and so they may not necessarily have sought healthcare, and they may not necessarily have excluded themselves from school, nursery, or other settings, and so the exposure has already happened in the community. In addition to that, it's quite a long incubation period for measles, and so definitely some people already have been exposed. And by the time we respond by vaccination clinics, again, once you get the vaccine, it's not immediately preventative. It takes 2 weeks to mount a response. So really, the best way is to get on top of this early and by preventative measures. We can do a lot in an outbreak response, and we have been doing an incredible response. And you can hear from Sonali and Dudu that there has been real sort of a response. But it really needs sustained medium to long-term prevention matters to control these pockets of outbreaks. And we've been having outbreaks since 2023. And when we have outbreaks, we know they're going to happen. It's just not necessarily where they're going to be. And it's likely to happen where we have pockets of very low vaccination rates.
Okay, so 71 would be the confirmed cases. When you're saying that you're notified of many more, what's that figure look like?
So we'll find it in the national figures for you, if that's okay.
I think we should. We're constantly data sharing, and and because of the added noise around what's happening, then obviously we get more reports of cases come in, and I can say that suspected cases. And there has been a report that's been put out that says that we got over 300 in London. So. Of suspected, and of course all of those are not necessarily confirmed and not necessarily all linked to Enfield.
Okay, because the question I ask about underreporting, Dr. Chow speaks to much of what you were discussing there, is that for the first few days of measles, and for many children this will be something like a common cold, which won't have any long-term effects. So that's why I ask about perhaps the underreporting, and what's the likelihood that there are many children whose parents don't realise that they have contracted measles, and they've continued to go to school and haven't sought any medical advice throughout that period until they feel better.
Yeah, so I think our surveillance systems in England is very good and it's very robust, and I think we capture almost most of those. However, yes, there may be cases that we have not presented to anybody. However, with the increased awareness that is generated throughout primary care schools, and you heard about all the letters and all the awareness going through to school, the community, and the wider system, everybody's on the lookout for measles cases. And in fact, we probably now see more that are not measles than we are of measles. So,
and the situation in Enfield, is that something that's classified as a major incident with the UKHS? How do you have a grading system or something like that?
Yes, we do have a grading system, and we do have incident, and we run quite often what we call a dynamic risk assessment on where we are. And for the Enfield incident, it has been a routine incident mainly because, since I said, we have had outbreaks throughout since 2023. The size of this outbreak is not unusual for something like measles, and we have had even more outbreaks in 2024 and 2025. However, we have always continuously reviewed the outbreak situation. We continuously monitor, and this currently is at an internal, what we call a standard incident. And again, nationally, we are looking at this throughout the whole country, including other areas outside of London.
Thank you. And Dudu, if I could just finish with one question as well to yourself. You might want to comment on how you've classified it within Enfield, of course. But could you also comment on the fact that we've talked about Enfield, you mentioned a population of 300,000, but as I understand it, this is an issue that's concentrated much in the east of Enfield. Did you want to talk about what those town centres, And obviously that's a smaller population, therefore, where these cases are occurring, as I understand it, in the most part.
Yeah, so it's probably worth just talking about, if we kind of start at the London level and then bring it down to Enfield. So London has an average vaccination rate of around just under 70% of MMR second dose at 5 years.
I think we'll get into vaccines. Sorry, I'm keen to move on to the other. We'll come on to the vaccines, but if you could just on how you've classified the event within Enfield, and also what are those regions within Enfield that are most at risk?
Yeah. So in any sort of situation of infectious disease, we work very closely. So not only measles, we work very closely with our UK HSA colleagues, and it is a standard sort of procedure to establish an instant management team, and that brings all of the relevant bodies together across the health and care system. And that is what we have at the moment. That's meeting very frequently, and there's a lot of sort of background work that's being coordinated through that meeting. So that is the standard response that we have. That's what's happening at the moment. And UK HSA and the local authority co-chair that work at the moment.
Did you where? As I believe it is the east of Enfield, isn't it?
That's right.
Where are those areas that are most at risk?
So the east of the borough at the moment has more cases than the west of the borough, and there is lower vaccination uptake on the east of the borough. But we are seeing sporadic cases in other parts of Enfield as well.
Great, thank you. Assemblymember Russell.
Thank you, and good morning, everyone. Dudu, do you want to turn off your mic?
Yeah.
It just works best if there's one of the mics on the panel at a time. So I want to pick up a bit more on containment. We've heard that that children could have measles for 4 days before their parents became aware that they had a rash, and so that's 4 days of children kind of still accompanying older siblings to the school gate and just going about their lives normally. So just very specifically, what are you doing to raise awareness about the need for containment, and what measures are there that are different from in other boroughs where there isn't a measles outbreak, that are aimed at containment? Yimi, you're nodding. Would you want to come in, or Nalini?
Yes, if I might start. So there's various levels really for containment. So if you take what UKHSA does with individual case reports, we would use contact tracing to help with containment by making sure that checking whether contacts are vaccinated, and if not, arranging that, and if not, giving them advice. Dudu's mentioned already that information's gone out to the residents, and particularly to schools and to parents around what measles symptoms look like and when to keep children at home if they're feeling unwell. There's general advice for schools and parents around keeping children at home if they are unwell, particularly with a fever. So obviously we don't want children to be home unnecessarily. But if you have a fever illness, then the general advice is that you keep your child at home. So there's a series of those measures. But so contact tracing, information, providing information to the population and to schools. So those are the main ways that we try and contain. But of course, the vaccination response being the most important of them all, and part of the information that goes out to the parents, and the most important part is, before you're exposed to measles, please make sure you check the MMR history for your children and make sure they are vaccinated. That really is the best way we have to contain this. Do you may wish to add?
Just though, picking up on that, you're talking about keeping children at home if they've got a fever. A lot of, particularly in communities where there are high indices of deprivation, parents are going to be under real pressure to get to shifts at work, and keeping children at home and off school is really challenging. And so how are you, yes, I mean, is that something that is posing a risk factor? And also, are you seeing children at siblings of children with measles, of confirmed cases? Are they expected to stay off school, or are they going to school? You know, what's happening there?
Yeah, so in general, the compliance with our advice is great. Schools are very helpful in trying to minimise the disruption to individual children and to parents. We completely sympathise with parents finding it difficult to keep children at home, but it's an important infection control measure for any infection to prevent spread in closed settings like schools. You picked up on contacts, on siblings or household contacts of children with measles. So there are individual risk assessments that we would do with parents. We would check whether the sibling was vaccinated. If not, we would arrange a vaccination, or at least advise vaccination. Hopefully that's taken up. If that isn't taken up for whatever reason, and it could be that it may be sort of too far down the line from the case in the index case, as we call it. So if that's not taken up, then yes, we might advise that siblings stay at home. It's done on an individual basis. It's done in discussion with the school, and we absolutely try and minimise the disruption. And schools, I think, hopefully Didi will agree, schools are very well geared up to help children and parents to continue education at home. But it's a balance of risk to the child and the risk in the school. So it's an individual risk assessment.
Didi?
I think as well, one of the pieces of work that is paying off is that we have as a local authority public health team, we have a long-term engagement with schools around, various conditions that children often get. So schools are very used to working with us as a public health team, and very used to working with the health protection team to seek support and advice, so that they do get so that they respond to, it can be a case of chickenpox, it can be all sorts of different things that are infectious diseases that are common in childhood. So we know that it's very important to ensure that schools are have a really good understanding of what the response is, what their responsibilities are, and where they can seek support and advice, and that we respond quickly when they come to us to seek that. So we have regular head teacher forums and various other education forums that public health colleagues go to on a frequent rolling basis to speak to schools about things like measles, the right type of communication to parents and such like. And I think that kind of preparatory work, that background business as usual work, means that when we do have this kind of outbreak situation, they're in a very good place to respond appropriately. And they also understand that they have a role in supporting the vaccine uptake, because really they are keen to ensure that their school communities are as healthy as possible, because that is protective of school attendance. And I think everybody is very well aware that, making sure that children can come along to school is the best thing for families and children.
We're going to be coming on more to vaccine uptake later a bit later on, but what evidence do you look at to tell you whether the containment measures are working and are being complied with? How you mentioned there are about 300 certified cases, or cases that may be cases of measles, which would be a worrying increase if those cases are confirmed. So, yes, what is the evidence that you look for to show that containment is working? I don't know who is Nalini.
So just to say, as Yamid said earlier, those 300 suspected cases may not necessarily across London may not necessarily be cases of, may not go on to be confirmed cases of measles. So that's the first thing. In terms of evidence that we're looking for at the IMT, we're looking for increase in activity in terms of MMR vaccines being given. In response to the question you had earlier, we have the option to, and we have held clinics in schools for MMR clinics in the past, and during this outbreak, schools work very closely with us when it comes to children staying at home, for example. So following that guidance, when GPs see cases, they will reiterate guidance to stay at home to help with containment. So these kind of various activities at case level, at population level, that we are reviewing during the IMT.
Mm-hmm. And do you think, because I mean, obviously during the pandemic, we all had to stay at home, and there was support put in place so that people could comply with that advice. Do you think that you might get to a point where there's a need for support, for financial support for households to stay at home if they have a confirmed measles case in the family and, say, an unvaccinated siblings? Because you said it takes 2 weeks for the vaccine to kick in.
It's difficult for us to comment on that. I think that, it looks like that, if we are correct that this outbreak is stabilising, that might be something if we have to consider, should we have more cases nationally, but given that this is a localised sort of outbreak to Enfield at the moment, then schools, probably one thing just to be aware of is that schools are very keyed in to their, to the needs of families and residents, and, part of the business as usual of activity of schools is supporting those families that are in financial hardship with things like food cooperatives and food banks, as part of a business as usual sort of background work. So I think that's probably all that we can say on that point at the moment.
Okay, Nalini.
If I might add something from experience rather than numbers, we do sometimes, even for other infections, get situations where families would find it difficult to cope to have children at home, or for the caregiver or the parent to be at home. And we work very closely with the local authority and with the NHS to provide the support that they need. So we have systems in place to talk to each other to say, do families need additional support? Yeah.
Okay, thank you. That's reassuring. Yimi.
Yeah, no, I just wanted to say that it's a slightly different situation from the COVID pandemic, and we have got a rolling children's vaccination programme in place. Vaccination is still the best prevention. We don't exclude children that have been vaccinated because they're unlikely to get measles even if they're exposed. So prevention is still the best route, I think, and that I don't think we'll be heading necessarily into this sort of, talking about payments and exclusion, because we have got lots of good coverage. It's just what we're seeing from these outbreaks are these pockets of specific pockets around London where the vaccination rates are really very, very low compared to even the London average. And there's great variation and great heterogeneity across all the London boroughs, as well as inside and within the boroughs that you've heard about. So if I give you some example of where the next outbreaks are, it's hard to predict, but what we know is probably is likely to be in those pockets of very low vaccination rates. So prevention is still best. We have got a good childhood programme. It's just getting upon everybody to ensure that we get those 2 doses of MMR or MMR-free in, especially to our children and young people.
That's coming across loud and clear. Just a final question, which is about the sort of business as usual health surveillance measures in Enfield and the surrounding boroughs to detect outbreaks of this kind. And do you think that are there any lessons for you to learn about those health surveillance measures that you have in place just for, when there isn't an outbreak going on, in terms of detecting this outbreak? Sonali, did you want to come in?
I can start off with this. I think you're right. I think we will. There's always, we can do better and more, isn't it? And that's what the outbreak is telling us. So we will continue to doing our call recall system, which we've got a robust mechanism in place. But as I said, we can always do better, using every opportune moment to have making that contact count, so that we are able to speak about raising awareness regarding these preventable illnesses that are there, ensuring that our clinicians are also aware. So when you were asking earlier about how do we do the containment, there has to be the high index of suspicion currently, which is why we are making sure that all our clinical staff are kept aware and sending out notifications to them about that, and really working with all our authorities across the board to have a very coordinated response to make sure that we reach out to our population and making those opportunities available, linking in with our hospital colleagues so that we make sure that we've got the infection prevention control mechanisms in place. So it really has to be, while the business as usual, we've got, UK has a lot to equally be proud of. We've got this, a robust childhood immunization schedule which is in place, and it's almost, we're a victim of our own success because a lot of us have not seen these illnesses because these had been eradicated. But we cannot be complacent. We have to ensure that we make sure every single moment that we see somebody who has not been vaccinated or has been partially vaccinated, we bring up this topic and ensure that we remove any sort of concerns that they may have and may not be coming forward.
Thank you. I think, Chair, back to you.
Thank you. Assembly Member Wilson.
Thank you, Chair, and good morning, panel. Nalini and Dudi, you've already touched on this a little bit already about the work you're doing with the schools and that sort of positive communication and engagement, I think, which is obviously crucial to this. Perhaps if you just elaborate a little bit further on what exactly you think the sort of impact on the schools is, how disruptive could it be, and what measures are sort of being taken to help those children that are at home while they're at home, and hopefully coming back to school quickly, but not too quickly.
I can start off on that one. So I think the schools are very well informed about, and this is part of one of for me the positive things that came out of the work that was done during the COVID period. We have established in Enfield a really close working relationship with head teachers and with schools, and we often attend our schools forums to talk about various things around infectious diseases, around immunisations. Head teachers frequently engage with our school-aged vaccination service, Vaccination UK. So I think that there is a lot of great communication and engagement within our system that helps us to provide a robust, coordinated response in the situation of an outbreak. So all of the schools, are ready and know what to do if and when they experience a case within their school community. All of those schools where cases have occurred continue functioning as normal, and I think that that's a really strong message to give about and is a reflection on the way in which the system works together to ensure that schools are able to do that. And obviously the sort of information that parents have and the cooperation that the school community more generally is really important. And so that's why the sort of information flow through to parents and families and caregivers is also really important. And in terms of the help that children have at home, whilst I can't speak to that in detail, one of my roles is a close coordination and a close sort of engagement with our Director of Education, who I speak to at the moment more or less on a daily basis with regard to, what's going on around the measles situation. So there's, and as a local authority, we have a role there in terms of helping schools to ensure that they are able to continue as a business as usual sort of function. So the whole team in the local authority, with regard to the from the director up all the way, through to the officers that support on school improvement and such like, are all very aware of the situation and are all working with schools to ensure that we've got a really robust way of supporting schools to continue, their main aim, which is educating pupils. And I think that the schools will take it on a case-by-case basis, and often, Nalini and Yimi have spoken about the way in which the UK HSA will, the identification of cases and identification of close contacts, schools. We share that information with schools, and they will be able to support those families on an individual basis, depending on the needs of those children. Whether those children are ill with measles, whether they accept vaccination and come back into school quickly. The school will work with families on an individual basis, ensuring that they are well supported, both from an educational perspective, but also from a kind of pastoral perspective.
That's very good to hear. And one thing in particular that you said that I'm very pleased to hear, that working with schools to make sure they can continue to function as normal. Because
yes.
During lockdown, I think the closure of the schools was one of the most catastrophic elements of that whole period, and the hugely damaging effect it had on not just academic progress, but that kind of socialisation and development of those early ages and mental health concerns. So hopefully we won't be needing to give much consideration to the idea of closing schools completely.
It's probably also important just to add that there is national guidance on measles and other sort of infectious diseases during childhood that is published by UK HSA. So we are all following the national guidance around how to deal with this situation.
I'm conscious that time's sort of ticking on, so my next question, fairly brief, hopefully. Again, it's about sort of impact of the outbreak, and this, I guess, to sort of Dr. Kinner and Dr. Chow, really. How many patients have been hospitalised as a result of this outbreak, and what wider impact could that have on hospital capacity?
So, as we said before, that measles is can cause serious illness, and so most of our figures show that at least 1 in 5 are hospitalised or admitted to hospital. So I can hand over to Sonali to describe what the local hospitals are currently seeing.
So we have, our local hospital has noticed that there has been an increase in the emergency presentation for these cases, again keeping a high index of suspicion. We've had 1 in 5, as Yemi mentioned, people have gone to the hospital. So these are not people who've necessarily needed hospitalization, as they would be treated within the emergency department. One of the things that we are most concerned about as clinicians is about risk of dehydration, which happens because of diarrhea, and that is what is seen sometimes as the presentation. But our local hospital has been able to discharge patients from the emergency department itself, but it does have a knock-on effect, as you would imagine, across the emergency department, because they need to ensure that these patients are isolated. So we have to make sure that side rooms are made available for them, which then also impacts the flow across the hospital, which may in some way slow the progress around emergency department. We've also had to ensure that there has to be contact tracing, and patients have to be sometimes be given what we call as the immunoglobulins, which are those people who may have come in contact, which means there has to be a robust follow-up mechanism that has to be in place as well. But what the hospitals absolutely have to focus on, that we ensure that there is early identification of if there's any complication that may be attributed to measles. But in most cases, they've been able to discharge these patients, though there is a very small minority of patients who may have had some complications. One of the other things we've again, with the staff, the hospitals have taken, again, actions to ensure if there's a requirement to redeploy some of the frontline staff depending on their own vaccination status. But the hospitals are very closely monitoring the situation and ensuring that their workforce capacity is attuned to what is coming through the emergency department.
Thank you.
One of the things that we've been doing as well is holding webinars and training for clinical staff to ensure that they are all familiar and up to date with the initial management and identification of cases within the various sort of healthcare settings, including community services such as health visiting and school nursing, and other settings that aren't necessarily those places that people may go to seek support if they've got measles cases, but nonetheless are aware. Pharmacies, dentists, and such like as well.
Thank you. Assembly Member Boff.
Thank you. You've been very forthcoming in your answers to the point where I've had to edit my questions substantially. So good on you. Thank you. How are local leaders working with the GLA and the London Resilience Partnership to address the outbreak? Who would like to answer that, if you can?
I can start us off on that one. So we have been meeting with all of our system partners during the process of this outbreak, and so we've got regular communication with the GLA, and GLA staff have been, providing us with that sort of system advice and guidance as well. And so I hope that provides some level of reassurance that all of the various parties who have a stake in this are all very much engaged and all very much supportive to ensure that our local outbreak response is functioning well.
Do you think it might be helpful if the GLA and TfL were to offer measles information on the TfL advertising estate?
So we have, we know that campaigns, whilst we do have campaigns that run, and there is actually a national campaign called, bear with me one moment, it's just started, Stay Strong, Get Vaccinated. It's just started during the last sort of week or so as a national campaign. It is running for the next few months, and we also in Enfield we run local campaigns. But
is that specifically, is that running on the TfL estate? Because obviously that's a very influential place. A lot of people will see those advertising. Is it running on the TfL estate?
I'm not able to comment on that at the moment.
Would it be helpful if it were?
I can't comment on that. I know that you've got, in the second part, you've got representation from the GLA on the panel as well. It's maybe a question for them. I think that really from my perspective, we know that campaigns have a role, but in terms of those communities where, that are underrepresented in our vaccination sort of statistics, the generic campaigns are probably not the most effective in reaching those, and the evidence indicates to us that engagement's the best way.
I do understand there's targeted campaigns, and they are the most effective. Ms. Ianga, what role does promotion have in increasing vaccination rates?
So we, particularly in an outbreak setting, we'd be very much guided by how the local authority wishes to engage with the population, because Dudu's right, it's very much this kind of community-led discussions rather than mass media campaigns. Not to say that we haven't been doing that as well. There's that element of the response too. But I think I agree with Dudu that it's a much more localized response we're looking for. And whether, again, I couldn't comment on whether TfL would be the right place to do that. But it's more sort of community engagement type of response that's important.
Sure, but if that facility was made available to you, would you use it?
That would be for a national decision, I think, or for a pan-London.
If it were made available to you locally, would you use it?
Again,
there are quite a few sites in Enfield that TfL run.
So my perspective is that campaigns have a role, but the real work that will enable us to.
So you wouldn't use it.
I mean, where my investment would go from a sort of perspective of a director of public health and would be into engagement with the local community.
And if we now move on, I think question 7 has been covered in previous responses. What are the reasons for the uptake of the sorry?
I think Assembly Member Russell wanted to come.
Did you want to come? Yeah, okay. You've already covered. We're looking at Enfield because of the infection rate being so much higher there than anywhere else. What are the practical barriers to people not vaccinating their children in Enfield?
I'm sure other colleagues will want to come in on that, but I can start us off. So, I think it's useful to think about this. There are societal barriers, there are structural barriers, and there are individual barriers as well. So, you'll all be aware that, since the 90s, our societal approach to vaccination has changed, and vaccine uptake has reduced. So I think that there is something there about the a change potentially in the level of trust that communities have in vaccination. There are structural issues as well. When we think about some of the circumstances in which families are working, are living in the east of our borough, in those areas of highest deprivation, we can, think about people who have, low income, frequent shift work, maybe in temporary accommodation or some other kind of sort of insecure accommodation. And we know that people in that sort of situation, preventative healthcare may well, in a very understandable way, not be the highest thing on their to-do list for the day. And so we very much understand and need to take into consideration those sorts of things in terms of the access that we have. And then there are also individual issues that we need to take into consideration as well. People may have, there is quite a lot of movement within our local population, people coming in and out of the borough quite frequently, in terms of moving around. And so that...
I understand that.
Yeah.
I understand that. But, London is London.
Yes.
Enfield's not unique in that respect.
That's right.
Plenty of other boroughs are very diverse and have a huge turnover. So
that's right.
Why particularly in Enfield?
So I mean, in a sense, I think that you know, in those sorts of factors, Enfield is not unique.
Yeah.
And we have seen outbreaks of measles in other boroughs.
Yes.
So, for example, in last year, and I'll bring Yemi in on that, outbreaks have happened. So I think that, you know, really what I want to say is any place where we have low vaccination uptake is at risk of an outbreak. It just so happens that this time it's Enfield.
Yeah. Yeah. Which communities have been most affected by the outbreak in Enfield?
So the outbreak at the moment is not specific to specific communities. It's more based on a geography of, you know, the communities that are living within our areas of highest deprivation.
Living closely to each other in East Enfield.
Correct.
Okay. Thank you very much.
Thank you. Dudu, I was fascinated by yours. I think you're the first health professional who's ever came here and not said, yes, I would love some TfL space if it was given to me. So that was really fascinating to hear, so that you wouldn't be keen to take that up. But obviously, being that you're here at the GLA, is there anything that you would ask for our next panel that they could help you with?
The way that I have been approaching this opportunity is really an opportunity to speak about some of the challenges that we have as a system, and that I don't think are unique to Enfield, you know, really to flag to the system amongst, you know, people like you who are working at a, you know, up the system, to flag this as a national concern, because, you know, whilst Enfield is unique in my heart in many ways, in these factors, it is not unique. And anywhere that we have low vaccine uptake, you know, which occurs in particularly many of our urban conurbations, you know, is an opportunity for us to think nationally about this. And essentially, for me, this is an issue about health inequality. And we know that people who are experiencing deprivation are least likely to come forward to, you know, take up what is rightfully theirs, the preventative health care. And so this is really a double whammy of how inequality plays out in our system.
Yeah, of course, but how is there anything that you would ask from the GLA to help you in Enfield?
I think some of, you know, we know that very localised community engagement is a really effective way of opening those conversations about vaccination and developing the trust that's required in the system amongst local communities. So I think, you know, thinking about ways in which we can invest in work like that is probably how I would respond to that question.
Okay, thanks. And I think Assemblymember Boff was getting into this within the localised context of Enfield, because obviously we have what we often say is diverse communities across London, but every borough tends to have a different kind of diversity, right? So
yeah.
When we're talking about perhaps those from ethnic minority communities, is there a particular community within Enfield that are vaccine hesitant? Or is it
there are
just
a range, you know, it's not one specific community by any means at all. And I think that, you know, by, you know, maybe further investment into community engagement within communities that are living in areas of highest deprivation.
Because it was my understanding that you were particularly concerned about uptake within the Kurdish community, and so made particular literature in Kurdish in Enfield.
Not specifically, no. We've actually been creating literature in many of our commonest community languages. We have about 90 languages that are spoken by Enfield pupils at home. Obviously, we can't provide translated materials or sort of material in 90 languages, but we're identifying the most commonly spoken, and we are, you know, creating both written literature and short films in various community languages. But, you know, in Enfield, I know that in other parts of London, outbreaks have sort of been more specifically within certain community groups, but that's not the case in Enfield.
Thank you. Assembly Member Harani.
Thank you. Just to probe that a bit further. So from that, what I'm getting is that the cases that have come through mirror or almost echo the profile of the area physically, geographically. Is that have I
very much so? Yes.
Okay.
You know, whilst it's difficult with relatively small numbers to be representative of a large population. Particularly the population of children and young people. The population is more diverse the younger that you look at it, if you know what I mean. And so yes, we are seeing cases, spread across the various ethnicities that are within our children and young people population. So absolutely, by no means specific to any one single community.
Okay, sure. And so what is being done to improve the vaccination rates in those particular areas impacted?
Yeah, so it's important for me to mention that we have been aware of and concerned about low vaccination uptake of childhood immunisations in general, and of course particularly measles, mumps and rubella vaccination. And so we have got a significant amount of work that's happened already that has gone on. We have a local multi-agency group called our immunisation and screening group that coordinates a lot of this work. And that's some of which I've sort of covered already, but the sort of work that group oversees are frequent engagement with schools and early years settings about vaccination, frequent engagement with residents. So, for example, we've held young people's events where we've talked about a range of health issues, including vaccination. We've had a series of what we've called town hall breakfast meetings, where we've talked about all sorts of different health issues that are of concern to local communities, including vaccination, and those have been held in local churches that have big congregations. And that's what we've learned is that it's really important to work with those sort of faith organisations, community settings where people come on a those are the settings that belong to the community, and we work with the leaders within those communities as well. We've had routinely our school-age vaccination service, Vaccination UK, has had a rolling programme of contacting the parents and carers of children who are under-vaccinated over the last few years and offering vaccination, and I think also really importantly offering the opportunity to ask any questions and receiving information that is accurate about that. We have also recently been allocated health visitor pathway pilot status. So we are one of 16 sites nationally that's been provided with additional funding to train health visitors and to run a pilot that will enable vaccination to happen within our health visiting service as well. And you'll be aware that health visitors are often one of the first contacts that a family may have, where vaccination is discussed, and often have an ongoing relationship with families. So have that ability to kind of really create a good relationship with families. And we've had investment over the last few years in various engagement and sort of community development projects that have worked with certain communities around sort of health and vaccination. So that's the sort of business as usual work, background work that we've been doing pre-outbreak. So you can appreciate that there's been a lot that's been happening already. In terms of the engagement and comms work that's happened since the outbreak has occurred. I've spoken already a lot about the comms, so I won't sort of go into that. But in terms of the engagement that's happened during the period of the outbreak, we've had a significant amount of engagement with our Enfield Faith Forum, and our school nursing and health visiting team has been out in our local shopping centres and community settings and in our schools as well, to sort of pair up with the catch-up vaccination clinics that have been happening in those settings. We've also had an engagement project that's been working across Enfield and Haringey, that has been using sort of culturally appropriate, language-specific communication and engagement with communities. And we are also about to start a process of additional training with non-clinical colleagues within our local system. So, for example, within our family hubs, within our voluntary sector organisations, to ensure that we've got lots of people out there in all sorts of different settings who are confident in having that conversation with families about vaccination, who, you know, are able to give the right messages, are able to signpost parents and families into the right places to receive vaccination, and are really able to kind of support with you know, the work that everyone is doing to increase vaccination uptake.
So given that obviously we've got the outbreak now and we've seen the increase in cases, has that actually translated into more parents coming to services to, you know, that are worried and then do take up the vaccine, or do make sure that they are taking it up, just to spur them on, given what's out there in the news?
Yeah, I'll bring Sonelia in a moment, but you know, I think yes, we are seeing a bigger uptick in demand for vaccination. What's clear to, I think, all of us is it is not big enough, and so we are very keen to, you know, we've got a real local focus on continuing with this work, and we've got a real local commitment to, you know, ensuring that we learn from our activities and, you know, tweak, change, do things differently. We're very aware that, you know, you know, if we are not seeing the demand come forward, we need to do things differently. So we're very much sort of holding that in mind as we go forward, so that we can properly learn from the various pilots that we've got going and that sort of thing.
I can come in with what the response has been through general practice, as well as very much a neighbourhood response. We've got general practices that are organised in what we call as primary care networks and federations. So we have provided 26 additional clinics. This has been from mid-February onwards, which has been about 118 additional hours and putting out about approximately 900 extra appointments. So this is during in hours, but we're also doing community outreach clinics. You know, as I think, as Dudu said, we're trying every single moment to have that opportune moment to be able to increase awareness and answer those questions and remove any concerns that may be there. Is every conversation leading to where they have agreed to bring the child or have not attended? We hope that that's the case, but we also know there's more to be done. So we're really using every opportunity, but really taking a neighborhood-wide approach as far as we can to work with other authorities and to raise awareness and ensure that these children are brought to those clinics. We've also got, even within, you know, our practices, so my own practice, where we've got somebody who is from a Somali background, and utilize them to really be, you know, use that language, kind of not necessarily have an interpreter, but use that language, kind of the person who's there who understands about what's quite that culturally nuanced picture, to be able to communicate with them, and to utilize that opportunity where they may be attending for a different reason, really utilize that opportunity to provide the vaccination there and then. So we're using whatever tools that we've got, but equally staying open to any innovative ideas that may well be out there where people are doing better.
Sure. So from a primary care perspective, so if you have children on your GP list that have not had their vaccinations, is there any work that happens proactively to look at that data, to reach out to those individual families to hopefully encourage them to come for their MMR vaccinations? Yes,
absolutely. And just this weekend, I was speaking with my colleagues, across all the 5 boroughs which are covered by North Central London. We have been, they have been sending out text messages that are there. People have been picking up the phone and speaking with the families to really ensure that we utilize every single opportunity that is there, but proactively. So you look at your list and see where are the gaps that have been there. We've got some missing immunization tool, which is inbuilt into our electronic patient record system. We utilize that tool. We look at the heat maps that are produced as well and really triangulate the data to ensure that any area which is specifically showing where the patients are not being reached. So we do that through text messages. We do that through telephone calls as well as there are reminders that are set up on each of these children's records, so that if they are attending for anything else, we would have that discussion as well. So this continues as a usual call recall, but during this specific time, there have been close to what we've been told, about 2,500 messages that have been sent out to ensure that we raise the awareness.
Okay. And you mentioned call and recall. So is that used routinely and within the area or the primary care networks that you have where this outbreak has specifically happened in the eastern part?
Yes, so the call and recall system is a usual system that is business as usual, as I said, because we've got the child immunization schedule. But specifically during the time of the local outbreak, we have been proactive and seen specifically where patients have not attended for the vaccines or have been partially vaccinated. We have reached out to them through using different communication channels.
Okay.
I can also come in just, and you'll hear from our colleague Susan from NHS England in panel 2. NHS England is the commissioner of our school-aged vaccination service, and in Enfield and in many other parts of London, that's provided by an organisation called Vaccination UK, and they have been a sort of central part of our outbreak response as well. They routinely go into schools to provide all of the school-aged vaccinations, and they also run catch-up clinics for anybody who has missed vaccination. And so we have had within Enfield additional vaccination clinics that have been put on by Vaccination UK. And one of the business as usual activities that Vaccination UK do is also to identify those children where there are missing vaccinations, not only MMR, but others as well, and to contact those families and to offer vaccination and to speak to them, about any questions that they have as well. So I think it's also really positive to important to consider that, even that those opportunities for parents and for caregivers to ask those questions are very important as well. We know that there are many sort of opportunities. There are many slots within our local system for people to come forward and vaccinate the children. But having that trusted relationship and that opportunity for parents and caregivers to ask those questions in a non-judgmental way is really important.
Okay, and would you, sorry, Dr. Chow, you want to come in?
Yeah, and I was going to say that, of course, there's all this activity that's happening in Enfield recently, but in anticipation of sort of outbreaks, because we have got suboptimal vaccination across London, there had already been a catch and offer campaign during the flu season. That's just happened to all London schools. So not only were the NHS in school giving a flu vaccine, but there was also an offer to every child who had not had the MMR to be offered also the MMR as long with flu. So we are trying to use every opportunity in every way possible.
Good.
We call that the evergreen offer, so that, you know, at whatever point a parent, you know, may decide to vaccinate their children, you know, even if it's after the sort of point at which it's generally offered, they can come forward. So, you know, MMR is offered, you know, at 1 and until very recently at just before a child starts school. It's more recently, this for the second dose, been brought forward to 18 months. But even if a parent comes forward with an older child, that offer is still very much on the table. And that's the message that we've been wanting to really drive home to parents is, you know, if you've missed the kind of routine point at which your child's offered vaccination, you can come forward at any point. And we've really been wanting to welcome families into the GP spaces, into the Vaccination UK clinics, to ensure that they can have this non-judgmental conversation, get their questions answered and make an informed decision.
Sure. And has misinformation been an issue in Enfield?
I think it's a very complicated sort of environment, because there are a lot there. Yes, we're all aware of a level of misinformation about vaccination, but I think it's important to recognise that that's not the only. You know, providing accurate information is not the only. You know, it's not the silver bullet to the question.
Okay.
If you know what I mean, there's no one sort of easy answer to this.
But where misinformation is an issue, how is this being addressed?
So I think for me, this is all about, it goes back to that really localised engagement and that development of a sort of information provision by trusted voices within a local community, in places where communities, you know, trust as well, where there is, you know, that people. So that's why we're working with the faith leaders, with community sector organisations, because we recognise that, you know, often, you know, the NHS and the local authority are not the experts and in, you know, really engaging with those communities, and we really, you know, work closely with our voluntary sector and faith sector partners in that.
Okay, and is that an approach you took over the COVID period as well?
Very much so.
Partners. I say that because the uptake rates for COVID vaccinations in Enfield were broadly in line with national averages, so a stark contrast to what we're seeing with the MMR take-up. So why do you think that is? Because generally when you look across areas, it tends to follow, you know, vaccination rates in general, whether it's MMR or other vaccinations, they tend to sort of broadly go in line. If there's lower take-up in one, there tends to be in others. So why do you think there's a difference there?
So I think that this, you know, when I think about our MMR2 vaccination rate in Enfield in comparison to the London average, we're about 5 percentage points below, which doesn't sound a lot, but I think when we look at averages, it hides the what Yumi has kind of referred to, what we've all been referring to, is the range. So it hides the pockets of low vaccination uptake, which in the situation that we are in the UK at the moment, where we have measles cases occurring, any pocket of low vaccination uptake is at risk of outbreak.
And are there any lessons you feel that can be learned from the COVID vaccination campaign to increase MMR vaccination rates?
I think that there are lots of lessons to be learned, and, you know, as a local system, we've very much taken the learning that you know, having information about all sorts of different health conditions, not only vaccination, that is provided by local leaders in places that communities trust is something that came through the COVID outbreak really strongly. That having a strong communication system between local partners, such that we've all sort of described is really key. Certainly the sort of work that we have locally, ensuring that our schools are informed about vaccinations, infectious diseases, other sort of health issues that are relevant to their school communities, it is really key as well. So there's lots of elements that we've taken forward in our local system and blended those into the business as usual. One thing that we also do very frequently that has been something that we've taken from COVID is frequent communication with settings like our adult social care settings, who, we know that there are many young adults who are missing their MMR vaccination, and that provides a sort of risk to settings where those young adults are often employed. In Enfield, we've got a big adult social care provider network. So that's something, we've been working with those organisations very closely as well. Just very briefly as well to add, we will be doing some learning activity based on this outbreak as well. And that's part of the usual approach to outbreaks that I'm sure Nalini and Yimi can go into, but that's something that we've already discussed and is very much on our radar as well.
Okay, I'm putting my parent hat on now, and I'm just trying to think about.
Hat be quite quick.
Yeah, it'd be quick. Vaccination. So when you're thinking about vaccinations, I'm trying to think of what parents have, what tools they have in terms of reminders. And you mentioned the text messages, but you get lots of text messages from GP practice about filling out surveys, etc. The only other real thing you have is the Red Book, which is obviously something you have to proactively look at to make sure that you're up to date and checking on those vaccinations. Do you feel there's a case for updating the Red Book so it's digitised in some way, shape or form, so that it's a bit more sort of on your phones as reminders to get vaccinated?
Yeah, I think in short, yes. However, I don't think that there is, that there's not a single straightforward response to that, because, certainly in Enfield, and this will be the same in many other London boroughs, many people living in our borough, have grown up somewhere else. Like myself, I didn't grow up in the UK. My primary care record doesn't include my childhood vaccination status. It just so happens that I've been able to ask my parents about what vaccinations. But, many people are not in that situation. And so there's not a sort of one single answer, and there's not an easy answer to that. And a lot of children have had vaccinations abroad, and those are often not easy to translate into our local clinical systems and into our into our UK vaccination schedule as well.
Yes, can I just come in? It's absolutely, we are trying to make every opportunity easier for parents to access vaccinations, and part of London and nationally, we've been trying to find ways to streamline vaccines, to bring vaccines forward. So, for example, the MMR used to be 12 months, and then at the preschool, we've tried to reduce sort of visits and making that second dose at 18 months. But nationally, and also through London, we have a London immunisation strategy and a London immunisation board. We have been looking at data. We have been trying to streamline, trying to review how we can make it more accessible, more up-to-date and more sort of user-friendly. So that's all part of our sort of London immunisation strategy, which the NHS and AXA and partners are all part of. And of course, we can expand on that in the second panel, because a lot of that work is done on a pan-London level, as well as with national. And it's also part of the measles elimination strategy in trying to make sure access is better and data sharing is more fluid.
Thanks. Assembly Member Russell, briefly, hopefully.
Very briefly, we've heard about Vaccination UK, which is a sort of national organisation being brought in to help with catch-up MMR vaccination, but we've also heard a lot of information about a local approach, a very culturally competent approach being really important. And I just wonder what evidence you have that a national organisation is going to be able to really help in this very hyper-local situation. I mean, do you have evidence about how well they do with sort of catch-up vaccinations in their business as usual work, for instance, with HPV vaccination or anything else?
So vaccination. We know from the evidence that providing children with vaccination in a school setting is one of the best ways of achieving a better vaccination uptake. So I think having that as part of our national system is really important. And, Vaccination UK provide this service across many London boroughs. And I think that they are very, therefore, familiar with, working with schools to nuance the offer. So for example, they will publicise to parents that, for example, with regard to MMR, that parents can request the non-porcine element of MMR vaccination if they wish. So they have that sort of, and they have, staff that can speak community languages, and, with regard to the very localised work in Enfield, we also link them in with our school nurses, our health visitors, who also provide that sort of local nuance, that local engagement. And they engage with schools really well. They come along to our head teachers forum very frequently. And I know that Susan will be able to give a bit more information about how they work. But there is there's local management of that sort of local part of their provision as well.
Thank you. That's very reassuring.
Thank you. We are about to break from our first panel today, but before we do so, I wanted to welcome Barnhurst Junior School from Erith in Bexley to the Chamber. You've joined us at the end of a discussion on measles and the importance of getting a vaccine as well to fight measles. So we're going to break now until 11:05 and then see everybody back here. And to those on panel one leaving, thank you so much for the time you've given us today.
Thank you.
Out at some point, and I don't know if you guys have places to be. You probably do, and we're already running late, so I will kick off and hope that others are coming shortly. So now we are on to our second panel for today's emergency meeting on the measles outbreak in London. So can I welcome back Dr. Yimi Chow, Regional Deputy Director from UK HSA, and then welcome to the panel Emma Duzzetti, the GLA Group Deputy Director of Public Health, Susan Eldon, Consultant in Public Health NHS London, and Catherine Richardson, the GLA Director for Resilience. So if I could come first to, actually, Yimi, I'll give you a break and come first to you, Catherine, if I can, and ask to what extent an outbreak like this has been expected in London. Sorry, I said this as well. If you want to move that, you can move it.
Oh, yeah,
but
I could
pull it by the base, not the head. That's what we get in trouble for.
Thank you. Tell me if I get too loud. Thank you. Thank you, Chair. So in terms of the expectation, I mean, you've had lots of evidence from health professionals and you have some more now. But kind of stepping back about the broader context for London and its resilience, we have, through the London Resilience Forum, we take agency updates from all the agencies that take part in that, which of course include our health colleagues, and they're very well part of that kind of community. So that includes the NHS, on an ambulance service, UK HSA, and through that they have been reporting into the London Resilience Forum since 2022 information about measles, information about vaccination rates, They ran an exercise back in January 2024 that was reported into the London Resilience Forum the next month in that February, and that was shared there. So certainly the information has all been out there and is kind of well briefed in as part of that normal resilience business.
Thanks. Susan?
So maybe just to add to that from an NHS perspective and a vaccination perspective, I mean, I don't think it's completely unexpected given the lower vaccination rates. But as Catherine has said, we have the Resilience Forum, we have something called EPRR, which is our emergency preparedness. And as Catherine said, we try to test these out. And so what we want to see is obviously that no outbreaks happen, but if they do, they're small and localized. And so the other part to that is when you said, was this expected? The catch and offer we did during the flu campaign, we've been very concerned about the lower rates across London and in particular boroughs and in particular communities. So doing that catch and offer in the schools, doing that call and recall has been something we've tried to accelerate in order to, I guess, prevent a situation such as this that's happened in Enfield. Thanks.
Thanks, Emma. Do you want to add anything? No? Yumi?
Yeah, thank you. So, Chair, yes, as others have said, in London we had anticipated these outbreaks, and since 2023 post-pandemic we have seen quite a lot of measles. There was quite a lot of cases in 2024, and in that, and recently in 2025 as well. But what we can't predict necessarily is where the outbreaks are going to occur, and so at the moment it's currently in Enfield. In 2025 it was Hackney had a predominantly big outbreak, and in 2024 where we had a lot of cases in London, we had over 1,300 cases. There was outbreaks, considerable outbreaks south of the river in Lambeth and Wandsworth. So it's not that we don't anticipate it. It's not that we're not constantly having surveillance, and we constantly have good surveillance which we give and share across all our partners. I think what it is sometimes it's not necessarily the actual cases, but the trends of where cases are and where we can see the projections may go, that we do even more anticipatory action or extra actions on top of the actions that we've already got.
Dr. Charles, just further from that, what is the cause of an outbreak? Where does the initial kind of start for that come from? Because you'd imagine, I mean, to a layman, the problem remains every day that there's low vaccination across London and people are travelling and having visitors every day. So what's the catalyst for a specific outbreak in a borough?
Well, the catalyst for any outbreak is when you have a susceptible population. Outbreaks will occur when there is people who are not vaccinated and exposed. And I suppose where you have low or suboptimal vaccination rates, coverage rates generally in the population, then there are lots of people who are susceptible and may catch measles. The best way, again, as we say, is not really to contain the outbreak when it occurs, even though we have considerable effort, and you can hear that with considerable effort. It is really the preemptive work that we have to put in, both to protect everybody who's vaccinated, but also the ones who can't be vaccinated. For example, the under ones and people with underlying conditions like immunosuppression.
And what is the consequence of the UK losing its measles-free status?
Can I just go back to explain what measles-free status mean?
Yeah.
So measles-free status is given to a country that can demonstrate that it's had sustained no endemic transmission in that country for 12 months. Now, the UK has managed to achieve that in 2016. It was slightly short-lived. And in 2018, due to a global resurgence due to a European resurgence of measles, we lost that status. We regained that in 2019, and then with the pandemic, and the reduction of all infectious diseases, including measles, that was regained. However, coming out of the pandemic in 2023 and with a global resurgence again, that we've lost that status. We have the UK measles and rubella elimination strategy in place to try and that has a goal. The goal is of more than 95% vaccinations of 2 MMRs across the population, ideally before children start school. And to deliver that goal is several actions. They include all the targeted efforts that you've heard about in certain populations, and in particular we're aiming for children and young adults to have that targeted catch-up, both in London and areas like Birmingham. Then there is the strengthening of all the activities that happen normally, whether it's through the GPs, community, or schools. And then surveillance is very important, because if we don't have that surveillance, we can't demonstrate that we are measles-free. And finally, sharing information. And that sharing of information means sharing of evidence-based information through to the public as well, us health professionals.
So I suppose that's a consequence. That's the action that we input. Is there a consequence reputationally across the world when you lose measles-free status?
Yes, it highlights that you haven't got your vaccination rates up, and it's not a position we want to be in. The UK as a whole is constantly reviewing that, and they have a board that meets. It's a tripartite board. It's a tripartite board with the Department of Health and Social Care, the NHS and UKHSA, as well as all the devolved administrations. So it's a status that we want to get back. It's a status that we would like to protect our population, but it's currently quite a high bar for London, and we have a lot of work to get there.
Thank you. And I'll come next, Catherine, and then Susan after that. What's the effect of losing that measles-free status on helping organisations on the ground and councils be prepared for a measles outbreak?
I'm not, sorry, could you repeat the question? I'm not quite sure what,
So on losing that status, clearly everybody is more alert. So what effect has that had on organisations, both voluntary and council-run and health organisations, on being more prepared?
Okay, so I mean, I think, if it's about raising the profile, then generally that could be a positive thing. Although obviously, as Yemi says, that status is not something that we would want, but really anything like this kind of evidence session that can help raise interest, I think is a positive. Has that impact in terms of the communications. I mean, in London Resilience, as you know, we do a lot of work with communities, with faith leaders, and so it's a lot of what we would do in this kind of space is about that ongoing engagement. You already heard in the first session about how much is about kind of building trust with communities, and then what we would do is take messaging from health colleagues and try and help amplify that through our own kind of routes.
So I would just add, when you think about the sort of frontline workers and you think about the kind of core vaccination teams, what losing that status means for them operationally. So I would say that losing or not having measles elimination status wasn't a surprise, seeing the coverage rates and seeing the previous outbreaks. So it hasn't been a kind of, huge revelation to those organizations. But what it does mean is we have to build in another element to our systems to respond to occasional outbreaks. And so what used to be, and I think the first panel was talking about business as usual, it was these organizations and everything that we had done was set up to do routine vaccination, to not have these coverage gaps. And now we're having to build in a lot more of the urgency. So, for example, like the school vaccination teams should be doing meningitis and HPV. We're pulling them from that to do outbreaks in schools. And so I guess very practically and simply, it means a lot more work for the organisations on the ground.
Well, that's really interesting. Thank you, Susan. Assembly Member Russell.
Thank you. And just picking up on that sense of more work on the ground, do you think you need like a sort of, do you need an extra task force of vaccinators to sort of help so that you don't, with this shift to having to deal with outbreaks rather than a kind of business as usual, just make sure everyone gets vaccinated? And you described the impact on HPV vaccination because people are being pulled from that to deal with outbreak vaccination. Do you think you need a sort of like an urgent task force to be dealing with outbreaks?
So I would say that there's something about the system flexibility. I don't know whether it is more, but I think that the main thing that has been very apparent through our London Immunisation Board and our strategy is we have to work differently. The way that traditional services of somebody just coming to their GP does not reach every single population in a high fluid population, a lot of movement, a lot of mobility, different language groups. In the DPH spoke very candidly about, the deprivation profile and people's sense of urgency. So this is very much about working differently. So it's like, how can we use every opportunity for access? These kids coming into school, put MMR on that consent form and make sure that MMR gets checked. Make sure that they're offered during flu campaign. The health visitors, it's not in their core curriculum, but let's start moving with that. Let's start building that in. Let's start getting them joined up. So it's all of these different elements of the workforce joining up to make sure. And the other thing is, it's not just measles. It's not, it's measles now, but it could be polio, diphtheria. It could be a range of things. And this is why the UK Health Security Agency, as Yemi said, there's a surveillance. So we need to stay very vigilant because the world is in a different place, London's in a different place, and so our workforce has to work differently but be in tune with where those diseases are coming from and if there are any hints of those flaring up, how we can, I think it's about rapidly escalating and shifting our work in different settings in different ways. Thanks.
And so are you confident that that the right support is being provided to all the various local agencies who have a part to play in this, and from that sort of London-wide level, and is the GLA doing everything that it could be doing to support this kind of shift from business as usual into dealing with a kind of, yes, an urgent situation? Susan, do you want to keep going? Or
I can start, and then I'll hand over to my colleagues at the GLA. But the level of confidence is, I will only be confident until we have 95% coverage and regain our measles elimination status. So, no, we're not confident that, that I think that's the first panel said it has stabilized. What we are confident about is, I think, the way that strategically we have organized ourselves at the region, at the local level, the frequency of meetings, the NHS system of meetings. We have capabilities that we can do to rapidly deploy things in place. Now, it's not ideal, but it is as good as it is. I think leading to the GLA, again, the other panelist had asked about, I believe it was committee chair who had mentioned about, how we were sort of preparing for this. The GLA, basically, we started 2 years ago with the early years and healthy schools, saying, okay, well, we've got healthy schools. Can we get vaccination in? And it wasn't actually us coming to the GLA in the early years. It was the early years coming to us saying, we think more can be done about vaccination. And how can we build this into the school environment, build this into the curriculum. The GLA is a member of our London Immunisation Board. They play a key role in the strategy. And then at the operational level, there's certainly the bit around the rapid response and that scaling up during emergencies. But even in, I would say, sort of peacetime and regular time, it's built into all of those just fundamental things that are happening, because we couldn't do this alone as an NHS. It has to be through local authorities, has to be through schools and those local structures. So I feel it's in a pretty good place, but I think GLA can comment more. Emma.
Thank you. Exactly as Susan's describing the Healthy Early Years piece of work, and it was September 2025 when that work was done and fed into that programme, so that for schools to qualify for their awards, they have to do some immunisation promotion work. But more generally, in terms of GLA response overall, you can see from the interactions in the previous panel and this one, UK Health Security Agency, NHS and local authorities are the lead agencies, the responsible agencies for the response to measles. But the Mayor has been working to fully support the work of those organisations and to play our part in that. The Mayor also has that role around keeping Londoners warned and informed of health threats. And that's why we've been working very closely with partners, particularly to amplify the communication messages for the population. So there are some things we absolutely do routinely. Susan's talked about the membership of the Immunisation Board for London that's chaired by Professor Fenton. But that's something we routinely attend. But in terms of actions for this particular outbreak, we're in regular contact with the UK Health Security Agency, NHS and other health partners to understand and actively monitor the situation. We are also represented on the London-wide Measles Regional Coordination Group, which is set up for us to think about the medium and longer term around response. We're also providing weekly updates on the evolving situation to senior GLA stakeholders. And then in terms of those communication messages, the Mayor is using the Mayor's channels through, for example, X, Blue Sky, Facebook. So the social media channels to really get the messages out there.
Sorry, can I just interrupt? Do you think that social media is enough? I mean, we've been hearing about the need to really get deep into community engagement to actually get that coverage and reach those groups where children are not being immunised routinely. So do you think isn't that too high a level? Is the GLA doing anything that's kind of really helping that deeper, more grassroots engagement?
Yes, so I would completely agree that the social media work and the work that we do around messaging and clear information is important, but it's part of a package of work. And I mean, you heard some fantastic examples from the previous panel around that engagement work. In terms of GLA work, one of the other things we've been doing is coordinating a GLA measles group, this is internal to the GLA, and then using the levers that some of those teams across the GLA have. So, for example, GLA Communities and Resilience, migration team and our schools teams, and using their more in-depth channel with the groups they're working with to channel those messages through in a much more, in a way that is more targeted in terms of where we can be from working London-wide.
Thank you. Yimi, did you want to add anything on this one before I come to Catherine?
Yes, I suppose I just want to add that you can hear it's multi-agency, it's multi-pronged, it's multi-layered, and I think that's the point. Each layer, whether it's national, regional, local, adds to the sort of vaccination coverage, adds to the response, adds to the overall sustained medium and long-term strategy as well. It does require this whole multi-agency collaborative work in which we have been doing very well and coordinated through the London Immunisation Board.
And Yumi, are you convinced that the need for these kind of urgent responses, that's not creating more risk in terms of some of the business as usual vaccination programmes not happening?
Well, that's it. I think it's a balance, and we have to be proportionate. The outbreaks that we're seeing at the moment are probably, it is anticipated and are sort of a little bit of business as usual. Like you say, we have well-established, well-rehearsed outbreak management response across our teams. There is a balance between how much we put in on responding acutely and also for the medium and longer term strategy. So that's where the balance has to be. But it all has to work alongside. I think the work that we're doing continuously all the time on making sure that the general universal childhood programme is really tip-top, is really fundamental and important. We can't keep on just having a lot of catch-up campaigns and not concentrating on getting that fundamental universal programme in. And on top of that, there's all these catch-ups that we need because we know we are not reaching all our communities. But that is on top of the acute response, and the acute response is difficult.
I think what I'm hearing loud and clear is that the business as usual of kind of making sure that everyone gets vaccinated and getting those catch-up vaccinations done clearly hasn't been keeping up with the backlog. And now we have an outbreak situation, so there's people who are involved in the business as usual programmes are being put into the kind of the urgent response. So do you need more resource to deal with this?
I think the short answer is.
So I wouldn't say it's a backlog. I think there's a general awareness. I think what happens is people forget that measles is very real. It's a sort of forgotten disease. And so I think there's something about it's not necessarily the top of people's radar, but right now in Infield, the systems are under a lot of strain because there's nothing like a very bad outbreak to remind people that sort of thing. So this isn't a very effective way of running a system. And I think that there's something societally that we almost sort of forget, that we take these things for granted. So I do think it's not a great way of clearing a backlog, but it does bring a lot of people forward to recognize then this is a real thing and this is a very consequential thing.
Yeah, well, I had measles as a child, and my younger sister, who was a baby at the time, was very, very unwell and had pneumonia, burst eardrum, and real serious consequences. So it's I know only too well the kind of what a serious illness it is. Catherine, the London Resilience Unit, how is the London Resilience Unit working with partners to support the response to the outbreak?
Thank you. So as you know, the London Resilience Unit works with close to 200 partners, and we tend to focus on the very top risks affecting London. So that's things like terrorism, flooding, and in the health space, it's largely around pandemics and also emerging infectious diseases. And of course, measles is neither of those two. So most of our planning for risks is around what we call common capability. So these are, do we have the right coordination in place, communication, humanitarian assistance, and most of the emergencies that we would respond to require those kind of common capabilities. So we don't have a kind of measles section, if you like. It's not something that we're kind of focused on, but rather we use those structures that we have and the relationships that we have through things like the London Resilience Forum to make sure that we're there ready to support, certainly where there's a requirement for multi-agency, and when I talk about multi-agency, I'm thinking about Blue Lights, about the Environment Agency, about the Coast Guard, and those kind of resilience partners that, should they need to be brought in, that we're able to do that.
And so, for example, the Mayor told us at Mayor's Question Time at the end of February that the London Resilience Forum would be meeting in the first week of March. So can you tell us what issues were raised during that discussion on the outbreak and what were any follow-up actions?
So the so the London Resilience Forum met, and there were two main discussion items around comms and around a recent review of resilience. So the measles briefing would have been fed in as part of the agency update. So these are the regular updates that all agencies provide in. So there wasn't a specific discussion around measles. Health colleagues were briefing in around the pandemic preparedness and around the recent exercise, the Tier 1 national exercise, Pegasus, that had been done on that. So we did have a good briefing from health colleagues, but we didn't discuss measles specifically at the meeting.
And do you think that measles is something that the resilience unit should be addressing specifically? I mean, the risk that it poses.
So I think it's good to be updated on it and to be briefed in as we have been doing. But I think, I suppose, going back to the start, we are very focused on those kind of top risks and those common capabilities. Susan, I don't know if you wanted to come in there.
I was just going to say, from an NHS system perspective, and this is again what Yemi was saying about the multi-agency, there's something about if that surveillance says, okay, we think that this is going to escalate, and then on the NHS capability side, if we say, okay, we've got a bed situation or we've got something structurally on the clinical side, then that's where that kind of all fits in together. But I think the initial indications, and so as Catherine's saying, this is why those internal meetings are so helpful in the sort of, I don't want to say peacetime, but the kind of now settings where we can keep an eye on the clinical systems, keep an eye on the surveillance, report that up, and then that can be instantly triggered and escalated if it is needed. And I think at the present, because it is maintained locally, there isn't an indication as yet. Is that fair, Yemi?
Yes, I think so. And I would like to say that also the LRF had been sort of cited on measles since 2023, 24, 25. We've had higher numbers previous years. There had been a multi-agency exercise called Exercise Juno in January 2024, and that looked at both our preparedness, our response and our recovery across the system for measles, and that fed into the LRF as well on February 2024. So I don't think much as the lessons that we got from there probably hasn't changed, and those are the lessons that we take forward on making sure that the healthcare systems, for example, are informed about measles, know what they do for infection control, know that they're what they do for their occupational health, as well as the wider system of getting immunisations up. So measles have been with us. It's not a new outbreak that we are. So this is maybe, I know it's concentrated and it's obvious since the start of the year that Enfield is the focus, but it isn't unexpected, it isn't new, and we have been exercising and continuously working as a whole system to manage measles.
So at the moment, you'd say that the NHS system is flexing to manage this outbreak, and you're confident that that at the moment it's all being managed within the business as usual system, but that you've got I'm just trying to check I understand correctly, but you've got the sort of monitoring processes in place so that if it needs to be escalated to the London Resilience Forum for a kind of wider sort of more emergency type response, you've got those monitoring processes in place so that you would know at the point at which you would need to go to that. And presumably, yes, I mean, how big an outbreak can you cope with under the kind of NHS system response?
I mean, there's a sort of delicate balance here between the epidemiology and all of this. But when you say how much can the system cope with, I think the thing with measles specifically is it flares up quickly. So that the issue with Infield, I think that it didn't startle us, but if it's in a school environment, in a big school environment, you can go from 0 to 30 cases quite quickly. Mm-hmm. If you hit a severity and that comes at the time of flu, that can have a massive impact. So there's an element of unpredictability with measles that creates a bigger challenge. So, and that is why, again, that multi-system coordination and that frequency of the meeting is so important, because there are certain, vaccine preventable diseases that aren't like measles. Measles is a very particular beast that can be very, very challenging because how it spreads so quickly, and it can, in the wrong age group or the wrong setting, trigger a severity as well. And that's why it's the volatility of it has put us all on alert, I think. Would that be fair, Yemi?
Yes, I think it will be fair, and you're right, Susan. It is about the concurrency of what else is going on at the same time.
Okay, and Susan, you mentioned the frequency of meetings as important. Are you having those meetings? Are those meetings happening frequently enough?
Too frequently.
Okay.
I think there is something about, when you think about the complexity of the NHS systems and the range of things from, cancer treatments and bedtimes and all of that. And so right now we have a little bit of give in the system because we are through flu season and COVID season. I mean, there will be a COVID spring campaign, but from a vaccination and prevention side, there's never a good time for a measles outbreak, but there is a little bit of flexibility in the system that we can do this. But as I said, these things do coincide sometimes when there are multiple things happening. But that again goes back to that resilience. So you look at that big picture in the round and say, where would this be on our risk table? Where would this be in addition to everything else? And where do we need to redeploy from other things? Digital, something else that may be having a quieter time. Thanks.
No, and I wanted to just also add that it has been flagged since 2023 quite often. We've been monitoring the measles outbreak to the LRF, but also it's not necessarily resources, but the amplification, the awareness in all sectors, because as Catherine said, the LRF has got a lot more members, including private sector and other sectors. It's just really getting out there in the population about the messaging that we want about.
Okay, so is the London Resilience Unit kind of doing everything it possibly can be in terms of spreading the information about the outbreak?
Yes, so we chair the London Resilience Communications Group, which brings together those agencies as kind of resilience agencies, and so as part of that, we're making sure that the communications around measles are being amplified through kind of it's a way to get into those different agencies. And we also have our team who, working in that kind of community engagement place and making sure, again, that messages are being amplified. But I suppose just going back to what Susan and Yemi are saying, doing that in a way that is proportionate, so making sure we're doing that, but alongside making sure that we're amplifying messages in other key areas, whether that's around flooding or something else, so kind of making sure it's part of that suite.
Overall resilience. Thank you, Chair.
Thank you. Assembly Member Harani.
Thank you. I think, Susan, you've already answered part of this question around vaccine and lower MMR vaccine take-up, about measles being almost this forgotten disease in lots of people's minds. But do you have any other reasons that you might want to add as to why the level of vaccination take-up is low?
I think it's a global thing that we're seeing. And, people use different terms, whether they sort of say vaccine fatigue or, and again, the first panel talked about this is, I think the average person, structurally our systems have changed a little bit in terms of, how frequently you go see your GP. You said in the first one about the Red Book, how often people use the Red Book. So there's something about our vaccination systems coming up to speed and coming up to date with the rapid changing of the modern world. And these systems were set up in the 1940s and 50s to protect against polio, measles, these sorts of things. But what we're having to do is really flex those systems to reach lots of different people in different ways. And so that's really where the kind of key thing is. I think the other thing to really remember is, and people often forget this, is pre-pandemic, I think there was just something about if the message came out, go get your vaccine, go see your GP, probably everybody ran to that. But now people are thinking differently, and they're talking about things differently. And so there's something about making sure that vaccination is an opportunity, is we're making sure that we're making that compelling case and that we're using all of the trusted sources, whether you go to church, whether you, are part of a local community group, whatever you need to do. It's about making sure that range of voices makes you feel that confidence in vaccination at the individual level. But it's also making sure that our structures are agile enough that we can provide it in schools, in primary care, and in a range of settings, I think.
Does the system almost need a bit of a reset or rethinking, really, about how it works in 2026 compared to when it was designed?
Yeah, I think the system is within the NHS. There's a number of things. So the new NHS 10-year plan is very much about the neighbourhood focus, because I think there is, as we can see vaccination rates sort of plateauing and dropping, the reason for that drop is the inequalities. It's these, geographical pockets of missed areas. And so that's, pulling down the vaccination rates. But unless we're thinking about communities, about individuals, about, really at that, just thinking about parents. And it was what you said, as I remember as a child, it's these conversations, and it's about having space and time to listen to people's concerns and all of that. And I think that it's really about making sure that it's about shifting how we're doing and building in that listening time, building in additional access, and thinking about different modalities. As you said before, social media won't reach everybody. It reaches some people, but it has to have multiple social media channels, but it can't just be that. And the text messages work sometimes. Sometimes it works coming from your GP. Sometimes it works when the school says, we've got measles in the area, make sure your kids. So it has to be multifaceted in the way that we're working now. Thanks.
And just looking at sort of obviously London as a city, because obviously a lot of the issues that you mentioned exist in other parts of the country as well. Are any of those amplified in London more than others? Is there a reason why London in particular, in our city, we are having a lower uptake compared to other parts of the country and other regions?
On vaccination uptake, it's interesting, because in past, I think, it has always been expected to come to London. So I think about it was in 2024 when it sort of manifested in Birmingham first. And so we were, in a way, tipped off. And we know that people travel, peri-urban areas, high mobility of populations. So we know the risk factors that create these disease transmission dynamics. And even within infield, when we first found out about this, we said, okay, what are the schools, what are the corridors, where are the family units, what do we know about this, and how can we sort of get in early and stamp on this? And I think because there were such a high number of cases in that school, it was almost like the cat was out of the bag a little bit too soon before we were able to, get very far on that. But London will, I think, always be at higher risk given the nature of the peri-urban population, the fact that it's a global city. It's not just a capital city, it's a global city, so that makes it more challenging. I mean, this is really UKHSA's bread and butter, which they have a weekly meeting to say what's on our radar this week and what's coming, which is very much how we get abreast of, knowing what to be most concerned about.
Sure. Dr. Jay, did you want to come in on that?
Only just to say that's absolutely what Susan's saying, that it isn't just London. There are other inner city areas around the country. Also, there may be specific events that have made a difference, but fundamentally, the outbreaks will occur if there are susceptible population, and once it gets hold in that population, it is a race to contain and manage.
And has there been any impact in terms of sort of structural changes, if you look at the changes that have come through in the last 10 years in terms of the NHS and public health systems? Because that's probably about the point. So if we're looking at the trends from 2017-18, it tends to be, you see a downward trajectory in vaccine take-up. Have structures had an impact on that? Susan?
So structurally, I would say that, when we think about what this was built upon in the NHS, it is that kind of person coming through the door. You have an IT system. The complexity of, because we don't yet have a child identifier, we cannot track children going where they're going. So we have something called a child health information system, and we have a GP record. Now, as the GP in the first panel said, that can flag up, but that flags up if they can, text that parent, if the parent changes their mobile number, if they move. So I think that the biggest changes, structural changes that we haven't seen, I think it's more the societal changes, is that people move around a lot more, and how these systems were designed was a bit of on a kind of traditional NHS model and a traditional family unit that is no longer, that is the main, that is still there, and that works for the majority of the population. But the majority isn't good enough with something that has an outbreak potential. You have to get to 95%. You have to reach everyone. And so that's what we're seeing is these big systems were designed for the majority of the population. We're having to make sure these systems are flexible and adaptable around inequalities and around risk areas, as well as maintaining that population thing. So I think that the conversations that are very live now are, how do you create an agility? How do you create a localized service that can respond to both at the same time? And that's a very live debate as to what you need to set up with digital systems and workforce and all of those. And it's much bigger than us at a London level. But I would say that London has the best experience already. So I think there is something about our workforce and our systems and those forums already being in place to kind of expect it to happen already, I would say. But
thanks. I think you've probably just sparked something in my mind. But is there more that can be done? Because housing, it sounds like, is very integral to this. So if you've sort of, had your children and you're living in the same place, in the same area, same GP, same services, it's a lot more simpler. But if you've been moving around, is there scope to work with local authority, housing departments, and even private estate agents around people who might be renting, moving, buying around London, and just having that as a almost informal checkpoint?
Yeah, I think housing's a great example, but what we're doing now is, so there's a big level of energy put in London around data triangulation. So let's look at school lists. So where do you catch the population, if you like? Housing, because again, with measles and MMR and vaccine preventable, it's the childhood ones. So housing can be, and yes, it is a lot of families, and that hasn't been one that we've historically explored. But what we do through the local authorities is through the safeguarding, through homeschooled, through the school rosters and all of that. So there's census population coming in. There's child health information coming in, and there's GPs. And what we're trying to do, as Yemi referred to with the heat maps, is get better at our data triangulation to say, and I'll give you an example that isn't Enfield, but Kensington and Chelsea, or areas of Westminster where you have a lot of private GPs or international schools. We found out there are 33 international schools that don't have measles recorded vaccination status. That doesn't mean that the Japanese school children don't have MMR, but we need to record that better so that that isn't susceptible. So it's the data triangulation, I think, is the way that what we're trying to do. But it's a great point about housing and thinking about this from a multi-sector approach.
And a final point from me. So when someone registers for their new school place after they've moved, or when they're sort of going into school, on the record, if it's showing up that they haven't had their vaccinations, is there any proactive work by the school nurses or anything at that stage to really follow up on those individual families? Because then you do have those details, you have their parents' details, and they should be all up to date. So that's a crucial point, really.
Yeah, that's been the biggest one that we've tried to do recently, is sort of twofold. So this is where it comes in flu. So you have those reception kids coming in for the first year, and then in secondary schools. But the offer is year-round throughout the vaccination. So it's basically when that child comes in, you have a class list, and you say, okay, do they have a GP register, and have they been vaccinated against our child health record? If any of those are missing, first of all, it comes out on the consent form. But the second thing is we provide a list back to the local authority to say, this child's come up. And so then this goes to then the safeguarding units of the local authorities to say, I've got this child on my class list, this child has a GP, but we don't have them on the school list, or vice versa. So again, it's kind of multifactorial, but we're primarily looking at vaccination. I think what we're coming across is there's kids missing on multiple fronts. And so that's a wider challenge, is these kids aren't just missing vaccination, they're also missing school, and there's lots of that. So again, it would be lovely to have a panacea and a child identifier. In absence of that, what we have to try to do is connect up at our systems level to try to get all of those different things flagged, whether it's school absence, vaccination, those sorts of things.
Thanks. And Susan, I think Assemblymember Wilson is going to get into this more, but so I don't want to tread too much, but just to say the point you just raised about Kensington, Chelsea, and Westminster, exactly this on breast cancer screening we had almost a month ago now, or a month and a half. But Assemblymember Wilson.
Thank you, Chair. So I think that last exchange has talked quite a bit about why London as a whole is performing less well than the country, and the figures that we've had for the take-up rate, clearly a much lower rate in London as a whole. But I'm keen to also understand differences across London, different boroughs. Obviously, today we've been talking particularly about Enfield, which has a lower take-up rate than the London average. Earlier on, Dr. Chow, you mentioned the areas that had outbreaks in 2024 and 2025. I think you talked about Lambeth, Wandsworth and Hackney. Do those have a similar vaccine rate as Enfield? Is there a common pattern there?
So the NHS takes, so it's interesting. So UKHSA produces the guidance, and they tell us about the schedule, and the NHS monitors then the coverage, and then jointly we produce something called a cover report, which is the uptake of childhood vaccination. So yes, I mean, where we've had, there's something that we always have, and this is a little bit of a technical discussion, but can we predict, based upon vaccination coverage, where outbreaks will happen? And our ability to predict has been quite poor with measles, because any child missing it, because of its transmissibility, it will pick up. So we have had measles, so specifically with measles, we have had outbreaks in Lambeth and other parts. The scale and the size just depends upon, as Yemi says, the susceptibles. But I would say from a coverage perspective, we have local authorities and borough areas and even LSOA areas where we know that variability is very striking. And some of that has to do with the demographic factors of the population. Some of it has to do with the location of GPs, and some of it has to do with our data reporting and where we see problems with that. That is a data problem rather than an actual coverage problem. So it varies a little bit. That's probably not a very clear answer, though, to your question. Sorry.
Yeah, no, I would concur with what Susan said. It's really complex, and you can't predict where the outbreaks are. And but when we do find an outbreak, and when we do find that there are real areas that we can really target, really get, really sort of engage with the hyperlocal community, then we do. And so, for example, a lot of work had been done in Hackney recently, and real local engagement with faith leaders, with relevant groups, to try and increase that vaccination uptake through that group. And sometimes, like Susan said, it's not the problem. The reason why it's low is really complex. Sometimes it's data, sometimes it's busy families, sometimes they've just missed it because they've got lots and lots of children, and the parents do want to get their children vaccinated, they're just not quite sure what they've all had. The schedule is complex, and that we are trying to simplify all the time. We're trying to find ways to make it easier for parents to have the vaccination. So lots of factors why certain populations may not have received their vaccines.
There's always, you're dealing with individuals, there's always an individual circumstance that prevents it, but presumably looking at more kind of aggregate levels, there must be some sort of trends and factors that you can kind of identify. I mean, wondering what, so yeah, Susan, you mentioned demographics. Are there particular groups that are particularly susceptible to not going ahead with the vaccine? I know in the previous panel, I think Dudu suggested that it's more kind of based on geography rather than demographics, but I would have thought the demographics are in some way driving the geography as well. It's not just a simple kind of postcode lottery, surely. There must be something underneath that's guiding that or driving that, and identifying that is I would have thought a helpful way of then tackling it.
So how we monitor this at a something called an ICB level and at our regional level and at the national level is we do look at all of these. So we look at deprivation, we look at ethnicity, and then we look at geography to see where those variable factors are. And yes, at an individual level, all of those contribute to this, but I think that the thing around this is also about access, and it's also about individuals. So, I mean, to give you a very I'm trying to think of a very odd example, but Richmond tends to have vaccination rates in the higher elements, but we have had cases. There was recently a nursery in Kingston, so it only takes a few, and some of those are down to individuals' personal beliefs. Some of those are down to, I think as the first panelist explained, is, because measles is almost a forgotten thing, people don't resonate with it here, or you may come from another country where that might not be part of your initial schedule, or that might not be the most important thing. So it's really hard to pinpoint, and that's why we have to do both the data triangulation at a population level, the monitoring, as well as keep unpacking those behavioral and individual factors that we think might be at play that we need to do better at our reach.
Thanks. Assembly Member Boff.
Thank you. Is it fair to say that if we don't attend to more public information about vaccinations, that we're going to continually play whack-a-mole with these outbreaks? Miss Eldon, perhaps you could answer. I mean, I know that there's no one solution to all the problem, but vaccinations is a big part of the solution, and yet we're not getting those levels high up.
Yeah, and so there's a whole sort of, so public information is such an important part of this. One of the things that we were talking about And it's really just been in January. So when we started seeing these first cases, we said, okay, advocacy messaging, but let's get the community groups, the vaccination, let's get all of that together at the same time. So it's not just the information, it's not just the billboards, it's somebody seeing that and saying, I can go right now and get that done. And so it's about combining up that public information at a time when somebody feels that it's convenient for them and they feel that that's really important for them. And sometimes people don't feel it's really important. They see the message, you know, they'll see the flu campaign and they'll think, oh, I'll get around to that. And they don't get around to that. And then, you know, they have the family gathering or whatever.
But it's, you know, they all play a part, don't
Yeah.
they? So the local campaigns, the public messaging, and all the rest of it, we're all partners
Completely.
in trying to produce that. For that reason, do you think it would be helpful if the Mayor were to allow that kind of public health messaging, that part of the campaign, not the solution to the problem, but that part of the campaign, if the Mayor were to provide that ability to provide that public messaging on the transport estate?
Well, so I would say that this is already happening. There is a Why We Vaccinate campaign that is happening region-wide, which I believe the Mayor is supporting that campaign already. So there are things underway. I would say specifically for this outbreak, we need to be much more tailored and targeted because the generic messages are not landing necessarily with those groups.
Yeah, they don't work on everyone, but
Yes.
they work on some.
Yes.
Mr. Zoid, I mean, will the Mayor be using the TfL estate to promote that campaign?
So I'm not aware of plans around that campaign and the TfL estate. But as you've really heard described here today, we know that behaviour change comes from a package of measures, including clear information, trusted local engagement, real access to services, and action that makes those choices easy, in essence, a tailored approach.
But is it fair to say that the Mayor's part of this, in London, the Mayor's part of this is to promote those global messages across London, because the boroughs and the local health professionals will be able to target those local communities which they know so well. So surely the Mayor's role is to promote those global messages.
So undoubtedly the Mayor's role is to warn and inform the population, and in terms of what the Mayor's already doing through social media channels and other routes, it is amplifying the messages that are coming either from national campaigns or more locally. In terms of would you use the TfL estate or would you run a big campaign, we've got to be really clear that that would have the desired impact to and would be worthwhile as a result. And what we do know, and actually you heard the Director of Public Health in Enfield say it, she would put investment in the community engagement side. So I think it is that package of measures.
That's from her competencies about the local response. I'm talking about the global response. And if it would it not be useful to have more forms of promotion than we currently have?
So I think we already have a number of routes for promotion, and I described some of those connections that
enough routes for promotion
has. Well, I think it's got to be promotion that we will understand will have impact and will make a difference to the vaccination uptake rate.
So presumably with that you want as many options as possible for that promotion?
Not necessarily as many options as possible. What you want is the most impactful options.
In order to improve that impact, you would need a number of options to choose where to place your messages, surely.
I think you would choose to place your messages where you know the evidence suggests they would have impact, and that isn't necessarily all the routes.
Yes. Do we measure the? Are there any measurements of the outcomes of the London immunisation strategy? Do we have benchmarks?
Yes, so the benchmarks, I mean, currently, and we do think it's right to be ambitious. So 95% coverage. And that, you know, our London immunization strategy benchmarks align with the national and the global ones. So we do want high uptake of all of those. I think the other thing that is sometimes forgotten, and it was mentioned, is, you know, there's 18 different antigens given across the life course. And so just recently we've introduced a RSV vaccine for older people and for pregnant women to protect babies. So some of this is also about successful introduction of new vaccines, but it also has to maintain absolutely the measles coverage and that primary infant coverage, which is dropping.
Yeah, forgive me. I mean, 95% is a target. It's not a strategy. A strategy is how you're going to carry out to meet that. What will you be doing to meet that target? And are there benchmarks? Are there key performance indicators on our route to that target?
Yeah. So within the strategy, there's an action plan, and that action plan is built into four pillars: access, workforce, innovation, equity. I should have brought, but there are pillars within that, and then within those pillars, there are a number of performance targets within that. So, for example, ensuring. I'm just trying to take an initial one. When we started rolling out with community pharmacies on innovation, or the health visitor pilots, for example. So London has been the first to do some of the more innovative access points, you know, in order to meet that pillar, which is hopefully spreading, again, improving access, which we hope will improve uptake. But I can give you specifics depending on which one. I will say that
it would be great if you could share with us. We're probably well over time, but if you could share that with us, it would be very much appreciated. Thank you, Chair.
Thank you. Dr. Chow, I wanted to come back to you briefly just to ask, because I think this is, to use Assemblymember Harani's phrase, parent hat on, a concern that many have raised is what is the risk level to those whose children are immunised?
Sorry, are you asking how safe the vaccine is? Or?
No, sorry. If there's a large measles outbreak in London, to those children that have been vaccinated, what is the risk of contracting measles?
Oh, right. Well, the MMR and the MMR-free, which is being used now, is very effective. And we know that at least the first dose, that's once it's been given, is over 90% effective of protecting you from the disease. And if you do get the disease, then it's less severe. With the second dose, then we're really getting up to high effective levels of 99%, both for the measles and the rubella element. So it is a highly effective vaccine and very protective. Of course, there are some people who cannot have the vaccine because it's live, and that's why we have to get the general population up more than 95% and at least 90% to protect everyone.
The important bit there as well that you highlight is how important the second vaccine is.
Yes, it is, because it increases that effectiveness to really high levels.
Yeah. Sorry, did you want to come in on that?
Yeah, just linked to that. So the cases that we're aware of now, are they largely in unvaccinated children?
Yes, I would say that.
Thank you. And just a final question as well to you, Catherine. What would have to happen with measles outbreak? How large would the scale have to be for it to be considered a major incident in London?
So we don't, for any incident, we don't have a kind of strict threshold, and it's based on lots of different factors. So in this case, I will be looking for health colleagues to be talking to me and saying we think it's got to this point. But my understanding with the way that measles works, and I'll turn to health professionals here, is that it's almost impossible at the minute for measles to get to that kind of pandemic stage because of the level of vaccination that we do have, even though it's not as high as we'd like.
Yeah, so I think the main thing is we take models on susceptibility from UKHSA. We then map that across what would be our, the main thing I think from a capability would be about the NHS systems. So what could the system cope with in terms of beds? And then if we think that that stretches beyond what would be modelled in that stretch that is there, that's certainly something that's flagged. So that's typically how it works with a disease outbreak, is to think, if we were taking up all the beds with an outbreak and that was what was modelled, then those beds would not be available for something else of critical importance. And so that would be a major risk. But I think that the current models don't suggest that. And so the current NHS bed capacity is at an okay level. That's not a very scientific term.
We like terms we can understand. So, yeah. Dr. Chavez, I think you wanted to add to that.
I would agree that we have well-rehearsed we have well-rehearsed EPR systems throughout, and each of the organisations have their emergency planning resilience criteria, whether it's called a deal level in NHS or incident levels in AXA. It may have different resources for implications for different partners, and that's where it's when the overall system is overwhelmed that we'll be flagging across to London as a whole. But we are definitely all aware of the risk, and we're all monitoring our different incident levels within our organisation and across London, and we're monitoring carefully.
Thank you. And with that, can I thank all our guests for attending today? Can I give Dr. Yumi Chow a special thank you as well for sticking with us for 2 panels? We do really appreciate it, and especially thanks to the guests, because I know we ran over time, so thanks for anything you may have shifted in your diaries to stay with us. That now concludes the discussion. Can I ask the panel, the Assembly to note the report and today's discussion? Can we also delegate authority to me as chair in consultation with party group leads to agree any output? Agreed. Thanks. The date of the next meeting is TBC, off the back of the 2026-27 establishment of committees. I have not been made aware of any urgent business, so that today concludes today's meeting.